This engine fires over 100,000 times a day. It is a high-output mechanical pump, continuously expanding and contracting with immense physical force. If you place this naked muscle directly into the chest cavity, that continuous motion would generate severe friction, tearing through adjacent tissues and eventually destroying the pump itself. There is also a volume problem. Sudden spikes in venous blood returning from the body can cause the heart chambers to stretch outward, risking acute overexpansion of the muscle fibers. This high-stress mechanical environment is located right in the center of the thoracic cavity, in a space called the middle mediastinum. To survive its own physical output, the heart requires a highly specialized dual-purpose containment vessel. We call it the pericardium. The pericardium is a fibroserous sac that completely encloses the heart and the roots of the major blood vessels. To understand how it protects the heart, we can reverse engineer this biological housing. We will break down its distinct dual-layer architecture and map the topological access ports, called sinuses, folded into its design. Finally, we will examine the exact clinical sequence that occurs when this rigid containment system undergoes catastrophic pressure failure. The anatomy of the pericardium is a precise evolutionary solution designed strictly to solve the physical constraints of a beating heart. Here is the outermost housing, the fibrous pericardium. It forms a tough, single-layered cone around the heart. Inferiorly, it blends into the central tendon of the diaphragm. Superiorly, the apex fuses directly into the walls of the ascending aorta and pulmonary trunk. This creates a rigid, inelastic tether. It firmly anchors the pump in the mediastinum and physically stops the heart from overfilling when venous pressures spike. Inside that rigid outer shell sits the serous pericardium, a double-layered blind sac lined by completely smooth mesothelial cells. The outer half of this sac is the parietal layer, which is firmly glued to the inner wall of the fibrous shell. The inner half is the visceral layer, or epicardium. It wraps directly onto the surface of the heart muscle. Between these two layers lies the pericardial cavity. Normally, it contains just 15 to 20 milliliters of serous fluid. This two-part system solves both of our initial engineering problems. The outer fibrous cone provides fixed, rigid anchoring, and the inner serous fluid drops mechanical friction against the chest cavity to zero. These mechanical layers operate under completely different neurological wiring. This diagram shows the innervation of the outer housing. The fibrous and parietal layers are supplied by the somatic phrenic nerves. Because they rely on a somatic nerve supply, these outer layers are highly sensitive to pain. The inner visceral layer on the surface of the heart is entirely different. It is supplied by autonomic nerves, making it completely insensitive to somatic pain. When a patient presents with the sharp, retrosternal pain characteristic of pericarditis, the heart muscle itself isn't feeling it. That signal originates strictly from the inflamed outer layers acting as a diagnostic sensor. The epicardium reflects off the great vessels in a complex topological pattern, following a path far more intricate than a simple sphere. These reflections create narrow communicating zones within the pericardial cavity, known as sinuses. During early embryology, as the primitive heart tube folds on itself, a connection called the dorsal mesocardium breaks down. This leaves a permanent horizontal gap called the transverse sinus. Viewed from above, the transverse sinus is bounded anteriorly by the arterial tube, the ascending aorta and pulmonary trunk, and posteriorly by the venous tube. This horizontal passage is a crucial access port. Surgeons pass a probe through it to safely clamp the arterial outflow. Understanding this topological layout allows a surgeon to isolate and clamp the arterial outflow of the heart quickly, without needing to dissect or cut through surrounding tissue. Below the transverse sinus sits a second major communicating zone, called the oblique sinus. Unlike the transverse sinus, which is an open tunnel, the oblique sinus forms a blind cul-de-sac. This animation shows its exact boundaries. The sinus sits directly behind the left atrium, framed by a J-shaped reflection of the pericardium that wraps around the four pulmonary veins and the inferior vena cava. This pocket provides a dead space clearance zone for the heart chamber with the most variable volume. The oblique sinus permits the left atrium to pulse and expand freely during diastole, accommodating oxygenated blood from the lungs without grinding against the posterior mediastinum. The exact anatomical property that gives the pericardium its immense strength Its absolute inelastic rigidity creates a critical vulnerability. Because the outer fibrous layer will not stretch, the entire pericardial cavity operates as a closed, fixed-volume system. If inflammation or trauma occurs, excess fluid can rapidly accumulate inside this closed space, a condition known as a pericardial effusion. This radiograph shows a chronic effusion. The fluid expands the silhouette of the heart into a massive, flask-shaped profile, commonly called a water bottle heart. Acute fluid accumulation causes a catastrophic mechanical failure, cardiac tamponade. The fibrous sac cannot stretch, forcing hydrostatic pressure vectors inward against the heart muscle. This pressure crushes the atria and restricts ventricles from expanding to fill with blood during diastole. With no blood entering the chambers, stroke volume plummets, systemic blood pressure collapses, and the patient enters an immediate lethal state of shock. Reversing this collapse requires an emergency intervention to physically depressurize the containment vessel, a procedure called pericardiocentesis. This animation maps the primary target coordinate. The needle enters at the left fifth or sixth intercostal space, placed just lateral to the sternum. Alternatively, the physician uses the left costocephoid angle, driving the needle upward and backward. These precise trajectories safely bypass the lungs' pleura to enter the pressurized cavity. Aspirating fluid removes the compressive force. The chambers immediately snap back to normal volume. Anatomy defines the physical boundaries of physiology. The structural blueprint of the pericardium provides the exact mechanical coordinates required to restore cardiac volume and save the life of the patient.